I'm very pleased to introduce our panelists for today's discussion on Massachusetts healthcare. Audrey Morse Gasteier is Chief of Policy and Strategy at the Massachusetts Health Connector. She leads policy development and strategy related to the Health Connector's role as a state-based health insurance exchange program and product design, policy research, government affairs, and outreach and communication efforts. Alan Macdonald is former president and CEO of Hallmark Health. Alan just retired, as he told me this morning, from the hospital after successfully finalizing a deal for the hospital to be acquired by parent company of Tufts Medical Center. But he remains proudly active at the Hallmark Health Board of Trustees. And Jennifer St. Thomas is Vice President, New Business Sales of Neighborhood Health Plan. Jennifer is responsible for leading the overall development, implementation, and ongoing management of sales strategies and plans to support NHP's successful growth in the commercial healthcare marketplace. Our President and CEO, Karim Hill, will moderate the Q&A session following the individual presentations. And as you're going through listening to the presentations, please think of questions that you'd like to ask our panelists, and we will have a microphone ready for you.
Good morning. Thank you so much for having me. Just want to thank NEBA for coordinating this event and inviting me, Karim for your leadership, and a burgeoning partnership between the Health Connector and NEBA that I'd be happy to speak about that we're very excited about. So as we look to the topic of price, which is sort of an ever important topic in the Massachusetts healthcare market, and has been for what feels like an eternity, but that keeps intensifying each year. I know my colleagues will speak from the perspective of carriers and providers and how they fit into that mix and what they see going on in the landscape. The perspective I bring from the Health Connector is the state's insurance exchange, which is the longest running insurance exchange in the country. We, of course, pioneered the concept of a marketplace or exchange as it was a part of our own health reform effort that was passed by law in 2006. So I can talk a little bit about that trajectory. But the perspective I bring to this conversation is how do we make sure that consumers, individuals, and small employers can navigate a landscape where there are constant pressures around price, where costs are increasing, insurance becomes more complex and more high stakes as price continues to be a challenge. So as I dive into that, just want to give a little context on what is the Health Connector, what is it designed to do, what is its history. And before I dive into that, I have to note that Alan played a really important role in early Health Connector and health reform efforts in Massachusetts in a past life when he was at the Mass Business Roundtable. So it's exciting to see him again today. He played a really critical role. So again, 2006, Massachusetts passes its own health reform law. That did a number of different things. It created an exchange, the Health Connector, which could be kind of a clearinghouse and go-to place for individuals and small employers in the Commonwealth to come and know that they were purchasing high-value, fair insurance products. That was created alongside a new program that offered subsidies to low-income people who were low-income but not eligible for Medicaid. It also created a program for individuals and small employers, so no subsidy involvement, just pure shopping for non-group and small group health insurance in the Massachusetts market. So we're a place where people can come and easily compare insurance options from all of the leading carriers in the Massachusetts market. Massachusetts is very fortunate to have so many locally grown carriers, nonprofits in our market. So creating one place that's a platform where individuals and small employers can come and really see what's available to them is critically important to competition and stability in our insurance market. So we've been working at this for over a decade, although markets have changed and health reform laws have changed, and we can talk about that as well. So that's who we are. We currently cover over 250,000 individuals, so 250,000 Massachusetts residents are covered through the Health Connector. So come and shop for their coverage through our platform. in addition to being a marketplace where people are coming and shopping for coverage, whether they qualify for a subsidy or whether they're shopping for unsubsidized private commercial insurance, we also play a policy-making role in the Massachusetts health reform landscape. So, for example, we set the parameters for the state's individual mandate, which it's important to note has continued since it was created back in 2006 and will continue going forward. It's existed alongside the federal individual mandate, which, as many people may know, is changing next year as a result of a recent federal law change. So our board of directors sort of sets the policy parameters for that. So again, in addition to being a marketplace where people come and shop using competition, using ability to compare to purchase coverage, we also play a policy-making role as well. So when we think about the role we play in terms of selling insurance to individuals and small businesses, anything that's sold through the Health Connector has to travel through its seal of approval process, which is the way that we determine that health insurance covers the basics, covers what people need. A component of that is also standardizing insurance products so that people can make kind of apples to apples comparisons. And what we found, and this is true on the individual side, and we're starting to see more and more on the small group side, is that allows people to make choices that they may not otherwise make on the outside market. People tend to find themselves buying products from carriers that they might not have necessarily considered off exchange, where people might be more prone to sort of responding to brand name, and it results in people buying lower cost insurance products. So that's an important part of what we do in terms of helping design the products that are coming to bear. The fact that we cover a large portion of the individual market in Massachusetts and are growing in the small group space means we think of ourselves as kind of advocates for the merged market in Massachusetts. So we're a component of the merged market. As you all may know, Massachusetts has a shared risk pool for its individual and small group market. So all told, that's about 770,000 lives in Massachusetts that are all a part of that important risk pool. And so what that does is bring stability to both the non-group and small group side of the ledger. There's about 460,000 lives in the small group market in Massachusetts and about 309,000 lives on the non-group side. And again, the connector covers about 250,000 of the 309 on the individual side. So we're kind of growing in scale there. So the tools we provide to people in terms of how they compare choices, look at price, look at quality, look at product design are really, really important. So I want to take a moment and talk about a new effort that the Health Connector has been undertaking over the last year, which is a refocusing on small employers in Massachusetts, who we see as potentially benefiting from a lot of the work we've done on the non-group side in Massachusetts, where we've provided tools for people to be able to make easier apples-to-apples comparisons. And what we found on the non-group side, as I noted, is when people shop through an exchange model, they tend to select lower cost plans that are still very high value. So we wanted to really bring that focus over to the small group side, which I will acknowledge has not been a key focus of the Health Connector since its inception back in 2006. We've predominantly focused on the individual market, but feel like the time is ripe to really turn our attention over also to small group as well. So starting last year, the Health Connector relaunched its small group platform in an effort we're branding Health Connector for Business. And we actually partnered with another exchange that had been very successful in its small group market, which is the DC Exchange. And what we've been able to do is relaunch a very modern, easy-to-use, nimble platform that any small employer in Massachusetts with 50 or fewer workers can come and use in order to shop for group health insurance in the Massachusetts market. And what's really novel about this, in addition to having all the carriers in the Massachusetts market there where people can shop from, we have something that doesn't exist anywhere else in the Massachusetts small group market, which is what we call choice models. And what this does is allow a small employer and their broker to come in, and if they want to offer what we call sole source, so they just pick one carrier and one plan and they want to make that available to all their employees, that's great, they can do that. All the comparison shopping that I talked about, that small employer decision maker can do, and maybe they find a plan they wouldn't have otherwise known about and they love it, and that's great, and that's what everybody in their shop has access to. So they can do that. They can also do two other things. One is they can select something called vertical choice, where they're picking one carrier but allowing their employees to select from a different kind of generosity level in terms of the benefits. So there could be something that's higher premium, lower cost sharing, or they could select something that's lower premium, higher cost sharing. Yes, exactly. So the other piece that's very novel there is what we call horizontal choice, and this is really more of kind of a disruptive technology, if you can think about it in that fashion, where the employer can come in and select one plan that they want to offer to their employees, set a benchmark, and then actually allow the employee to take the amount the employer is willing to contribute to that and then shop between different carriers. So really kind of setting them loose in the marketplace. So it's kind of atomizing the decision making of the small employer's employees and really setting them loose in the market. So we did this based on lots of feedback from the small employer community in Massachusetts who had told us how important choice was to them and to their employees, and hearing for so long that small employers are looking over their shoulder at larger employers who have access to that kind of choice for their employees and feeling like, that's not fair, I could really benefit from that. And for a lot of small employers, they may know they have one employee who has higher health needs, and so they kind of buy up to that highest common denominator in terms of generosity or brand name. But the truth may be that they have employees in all different kind of lots in life and may want to make very different choices with a set amount of money. So that is really new and novel. So we're bringing that to market. That doesn't exist anywhere else, and it really leverages what we know we do really well on the non-group side, which is give people tools to make choice and leverage how robust and competitive and diverse the Massachusetts insurance market is. So we're really excited about that, and we've been excited to partner with NEBA, spreading the word to small employers across the Commonwealth about that. The last point I want to make on Health Connector for Business is how critical our partnership with the broker community has been on this. So we worked really closely with the broker community. We have a broker advisory council we've worked very closely with, where we've really strengthened the relationship with that community. We welcome partnership with brokers. When a small employer comes to shop for coverage, they can bring their broker along with them. Their broker can partner with them on their plan selection, et cetera. We make sure that our broker commissions are competitive and transparent with the outside market, so there's no kind of loss for brokers that work with us. And for a new small employer that wants to come and shop with us, our website allows them to find a broker for free anywhere in the Commonwealth who speak any number of languages. So we make it very easy for small employers that are maybe offering for the first time and don't have a broker to find one. So that's been critical for us. A couple last points. Why does choice matter? I mentioned that people that shop through exchanges like the Health Connector tend to make different decisions than those that do on the outside market. They tend to be more price sensitive, and they find their way to lower cost plans. So that's one of the ways that our tools and our framework help the price conversation, help the cost conversation. We actually learned last week, looking at CMS data from across the country, the Health Connector has the lowest average PMPM plans of any exchange in the entire country. And so, like I said, most of our shoppers right now are on the non-group side, but all of those plans and that lowest cost exchange plan in the country on average is available to small employers in Massachusetts. And again, those are very high quality plans that cover all the benefits everybody would ever expect, that are very generous in our market. And what we're doing, the reason that those prices are so low is because of the scale the connector brings to bear and the fact that so many of our shoppers tend to be very price sensitive. So that's important for small employers to know that, again, though Massachusetts is a higher cost medical state, we have the lowest cost exchange plans in the country. So looking forward, we want to continue to deepen our tool set for consumers and small employers in terms of how they shop for coverage, how they look at it, how we can give a stronger line of sight into sort of apples to apples comparison so people can choose the plan that's best for them. We've seen that be very successful on the non-group side. We think it can be as successful on the small group side, and we think small employers in Massachusetts really need it. Small employers in Massachusetts have really been the backbone of a lot of the coverage expansion success that we've had over the last 10 years in Massachusetts, and I think we owe them more in terms of tools to try to bend the cost curve, tools to make sure that they're able to offer high quality coverage to their employees at premiums that are not going to be overly burdensome to the employer or the individual. So I would encourage anyone who is a small employer, working with a small employer, to explore these options. I think the work we have cut out for us is that many small employers in Massachusetts don't know that we exist for them and that these tools are available for them. So would certainly welcome your partnership and help in spreading that word, and really excited about our partnership with NEBA to do just that. So I will pause there, and I'll look forward to any questions after the presentations by my co-panelists. Thank you.
Thank you, Audrey, very much. And just a plug for the activities that I heard mentioned for the next few weeks' time. For those who have a chance to play over at Belmont, don't miss the opportunity. It's a fabulous setting, and the grand ballroom is very grand, too. I've only been there once myself, but it's a fabulous spot, so take advantage of that. I want to talk a little bit from the business side as much as from the healthcare system side. And that is that if we went back to put a healthcare system together in the U.S. Now, I doubt very much, I think we all doubt that business would be asked to be a major payer into the healthcare system. But as a historical fact, we're in the middle of it on the business side, depending on business to stay involved and to help the employee group and the general public get good health care. And of course, we all know that happened during the 1940s when Second World War. For those who haven't been part of the industry as much and watching this, we saw when wage and price freezes were in effect in the Second World War that it didn't apply to health care benefits paid to employees. So one of the ways to attract employees, well, you couldn't through the wage and price situation, you could through the benefit world. And when the World War II was over, 25% of our workforce was on insurance coverage paid for by employers. And during the 40s and 50s, as we all know, it grew to first dollar coverage for insurance right through the industry, so that 2/3 of all the workers in the country were paid for their insurance by employers. And it worked tremendously well because it wasn't costly. We had an economy that bore the expense. But in the 70s and 80s, as the international economy took over, and we decided as consumers to buy from Korea, Japan, Sweden, anything except for the U.S. on expensive items, the health care costs that were built into the products that consumers paid for and helped the employer provide health insurance for the employees was going away. That economic formula that worked in the 50s and 60s wasn't working in the 70s and 80s. And we noticed a tremendous change in the 1980s on the expenses that had built up over those 40 years through a lot of subsidy, a lot of commercial subsidy and public subsidy. Public subsidy, of course, through Medicare and Medicaid from the mid-60s through to the end of the 80s, to the point that a lot of things were being done to change the way we paid for the system. And the challenge we have now is to find a way to continue paying for the system, but keeping value in the system so that we don't lose the tremendous advantage we have in this country of terrific health care. We know that we don't lead the world in longevity and those kinds of things, but there's a lot of reasons for that that don't have to do with the fact that we have terrific health care. And what we started to do in the 1980s, we changed from managed care. We looked at managed care situations where we matched up a certain population to the expectation of diseases and procedures that were required, and signed up for what those costs would be. But of course, when you go outside system, the formulas didn't work, and the employers, frankly, didn't resist going outside the system, because that was at a time during the 1990s where economy was high and really was an employee market. You were looking for good employees and trying to reach out to them. And so what happened in the industry was a lot of consolidation. The industry said, we can provide a cost management if we can put community hospitals and academic medical centers together and provide a spot for appropriate care for patients that want primary, secondary care but don't need the high level of academic medicine. And that particular consolidation is still going on, as you know. And the idea behind it is that we have seen a tremendous, in this state, tremendous buildup in branding for the academic medical centers. And rightly so, terrific places to go where we all want to go, frankly, when we need our health care. But we don't all need to go when we need to have our health care taken care of. But in order to have those centers, you need a tremendous overhead to keep them going for the most difficult cases that are going to come in the door. But when less than the most difficult cases come in, those are more expensive to handle because you've got the built-in overhead naturally to take care of things, which has come over the years from both commercial and public subsidies. And the subsidies are going away because the system is very expensive now, and we can't afford the subsidies at the public level, frankly. You see everything else being pushed out in the other sides of public budgets in order to take care of the healthcare budget. Understandably so. And so the pressure for the industry and for the public leadership is to convince the patient base, frankly, that going to a community setting, to a less than academic medical center setting for relatively routine care is a sensible way to go, not just economical, but a very sensible way to go. And so we see in the industry a lot of attention to building things that aren't necessarily hospital-centric. You know, ambulatory surgery centers where day surgery is more common now, and we all can remember, if we're old enough, that you would be in a hospital bed setting for 4 or 5 days for relatively routine operations. That's not the case anymore, as we all know. It's really being taken care of during the day and going home that night to your own bed. And of course, that was where healthcare prior to the mid-1900s was most seen. Home care, hospital care was really something that just built up in the second half, from the middle of the 1900s to the second half of that century, because prior to that, a lot of charitable care, a lot of home care, and hospitals were something that grew when we could afford to be in them. It was very unusual. I want to turn over to Jennifer in a minute and leave time for questions, but very unusual in the law of economics when you see supply and demand kind of meeting at a certain point. When supply gets more than the demand, it's going to come down a little bit, and when the demand goes up, supply goes up. What we see in healthcare is the more supply has gone up, the more demand has gone up. There really doesn't seem to be an equilibrium on an economic scale. And so as we have built up the opportunity for healthcare over the last 50 or 60 years, every time it's built up, the demand goes up to meet it, as we know. And so now the situation is to find a way to respond to the demand in appropriate settings that the hospital network in the 50s, 60s through the 80s was built up to take care of, but we don't need that full system for all the healthcare needs that we have now. And different kinds of costs, as we know. The pharmaceutical costs are much more than they ever were, even 20, 25 years ago. That's another element. When we started to look, I'll close with this and then turn it over to Jennifer. But when we started to look at healthcare costs in the 1980s, the Mass Business Roundtable did a paper in '81 with the 10 things that we would see important in a system in the United States, building on what we have, not just taking it all away, but accepting what we have, but building on it. And we said the number one first thing out of 10 things was everybody needs to be insured. And the need to be insured had to do not just with economics, it was more health conscious as well. It was more important to reach people who needed health care before it was a serious need. It makes a lot of sense healthcare-wise, naturally, but it also makes a lot of sense economically. And so from the business perspective, we said we need to stay involved, and that led to the free care pool in the mid-'80s, which was a temporary solution for taking care of free care and bad debt in the system, so it wouldn't be just borne by the healthcare system alone, but generally across the society. Lots of experimentation between '86 and '06, but it led to the individual mandate, which was a very, very important piece that other states, for some reason, haven't been able to accept. But it's so important, I would say here, that business stay involved in this, recognizing the importance of the history that has brought business into this picture as employers of employees that get subsidized for health care. But the costs need to be controlled and managed, but with business involved, with public leadership to pay attention to how to get appropriate settings, how to convince the patient base where they need to go when the health care is appropriate for them to be looked at. It's a very important piece that's making it work. Here we are 12 years later after the individual mandate, still a very successful piece, in my opinion, for this state, and did lead, of course, as we know, to the national picture, which isn't operating the same way. We would try to say to them, we could help you out if you wanted, but it's important for us here in this room to know that the Massachusetts business groups stay involved and be very close to helping this system mature to the next spot, which is about appropriate care in organizations like the one I'm involved in here with Wellforce now, that has community settings, has academic medical settings, and has out-of-the-hospital network settings. And that's very important for us. It's going to help us in the long term to manage the cost growth.
Thank you. Thank you. I just wanted to thank Susan and Karim and Sophia for having us here. I'm really excited to share with you just some of the changes that have been going on at Neighborhood Health Plan, because if you looked at us probably a couple of years ago, we've been changing dramatically, and our focus has really been on commercial growth and growing to be the preferred carrier of the employer group community. And we're in a unique position because we're the only health plan in Eastern Massachusetts that's actually owned by a provider. So in 2012, Neighborhood Health Plan was purchased by Partners Healthcare. And so our strategy in the employer group space is to really, in the short term, differentiate through our customer and member experience, and in the long term, focus on differentiating through the patient experience with collaboration with our parent. And the other main change that's been happening over the last 18 months is that we've been really focusing on building out our provider network. So I think, if you had looked at us, maybe 12 months ago, we might not have every PCP and specialist in the greater Boston area. That's changed significantly for us. So now when you look at our provider network from Worcester County east, we're really on par with all the major carriers and having those PCPs, those specialists, and those hospitals. So I just wanted to provide you that little bit of background, because it has been an exciting time to be at NHP. We've been rolling out a number of new products and services, and our focus still is on trying to create affordable solutions for customers. So one of the advantages that we have, because we're owned by Partners Healthcare, is that we have a lower administrative cost than other plans. So we're able to leverage shared services with our parent. We use Partners Healthcare for our HR department, for our IT department. So by having lower administrative costs, then we're able to pass that savings on to our customers. Also, based on our history as a plan that had exposure in the mass health space, we're also able to leverage lower provider unit costs. So we believe that the price we're paying for services is lower than the other plans, which is also going to translate into premium savings. Thirdly, we're working really closely with Partners Healthcare to manage chronic conditions in a new way that is making it easier for patients to have their chronic conditions managed. We're trying to move away from the model where your nurse case manager from your health plan is interrupting your dinner time, and instead, your provider is sending you a text message and reminding you to take your medication. And so we think the combination of all three of those things is going to allow us to have a lower sustainable cost position for employer groups in the future. The other two things I wanted to mention quickly were some innovative product designs that we've been rolling out at Neighborhood Health Plan. So the first is our Care Complement Plan. So this is really taking, I think, the opposite approach that we've seen in this market, where in order to control utilization, plans have just been increasing cost share for members. So deductibles have gone up, co-pays have gone up. And what we've looked at is, in this market, the provider community, as Alan's mentioned, has really been transforming themselves and really being on point to control that utilization with the proliferation of risk contracts. And so, because utilization trends have been so low, we wanted to take a fresh look at our plan designs and to try to find services that we could carve out and actually reduce or eliminate the cost share completely on, so that members have an improved incentive to get care. So let me give you an example. It's been clinically shown that if members go to receive cardiac rehabilitation after a cardiac event, they're less likely to be admitted to the inpatient setting. So why do we have cost share on that benefit? It doesn't make any sense. We know that members that receive physical therapy are less likely to go to surgery. So on these plan designs, we're actually completely waiving the cost share on the first 6 PT visits so that members are going to get that care instead of going directly to surgery. The other thing that this plan includes is some advantages to try to help manage the opioid epidemic that we have and create some alternatives to receiving pain medication. So we're waiving the first 6 copays on chiropractic care and for acupuncture care. And we're also waiving the copays on 11 of the most common generic medications. So this has been really well received by the employer community. We launched this in the large group space for January. On pretty much every large group account I've sold, we're including this. We're excited to be able to offer this to small groups as of July 1st. So we're going to have 6 plan designs where groups are able to buy this. And what I've heard from people in the industry is, this is better than any wellness plan. It's really targeted at the people that need help, rather than, putting another fitness tracker out there that just the people that are already running marathons are going to take advantage of. So we're excited to announce that. The second thing that we've launched as of April is a new tiered product. So one of the challenges with tiered products in this market is that they're very complicated. And so it's sort of daunting to bring this to your employer group because you're wondering, how are people going to navigate this? Are they really going to be able to understand, to utilize this plan? And so our tiered approach, we call it the easy tier product, is that we're not tiering things like PCPs and specialist visits. We're just tiering services that are happening at the hospital, so your outpatient services and your inpatient services. And we're actually waiving the cost share, so we're not tiering lab, which is really important. There's all these, members don't control where their labs are being sent. So to apply a tiered cost share and act like there's some decision-making process happening, it just doesn't make sense. So, we sold many of these on our small group segment for April 1st. We're excited about our competitive rates that we filed for starting in July, and the member experience and the enrollment process has been very positive as people feel like these are easy plans to understand. So with that, I'm going to hand it over to Karim.
Thank you, Jennifer, and thank you to all the panelists. Larry Siff wisely said, and when I say wisely, when you talk about Larry, that's a very coded word, but Larry Siff said to me, he goes, Karim, have you ever moderated? And I said, no, right? And I said, well, what you do is, what I learned, Larry, is the higher quality your panelists, the less you moderate, right? Because your panelists are so good, they carry the thing themselves. So that's kind of my MO. But so what we'll do for the next 10 minutes, I'll ask a couple questions of the panelists, hard-hitting questions. I mean, really, really Bryant Gumbel level questions, okay? And then once we get through that and they're all sweating and lathered up, then I'll turn it over to you guys, okay? So the first question I do want to ask, and Alan, you kind of touched on this, but I'd love to get more detail on this. So Massachusetts is the highest per capita cost in the country.
Yep.
Why? I mean, in simple, plain English, why?
Well, the first reason is because we have academic medical centers that are world-class, and half of all the bed days in this state when people go to hospitals are in academic medical centers. You could fly from Idaho to Minnesota and not go by an academic medical center. But here you could walk across the street from one to the other.
Yeah.
So that's the simplification. But we have a higher percentage of acute care overnight stays in hospitals in academic medical centers in this state than any other states, about 50-50 for community care versus academic care. And a lot of the overhead that goes into that has to take care of the rest of the system. That's the simplification.
Makes sense. Jennifer, anything you want to touch on to that in terms of from the carrier side to elaborate a little bit more on why the cost is just so high in Mass?
Yeah. I think the other thing I'd add is, Massachusetts has been historically very paternalistic with employees. So when you look at some of the things that are happening across the country, like defined contribution strategies, where employees are given a set amount and then asked to shop for different plans. We just don't see high adoption of that type of strategy here in Massachusetts. The other strategy that you see in areas like Pittsburgh are limited network strategies, where you're really focusing around a set group of providers. And as we've evaluated this at the plan, you just don't see that willingness to really move towards a more smaller, narrow, tighter network. And so I think some of those things culturally too that exist here in Massachusetts have prevented some of those cost-saving strategies from really gaining momentum.
Yeah, very good.
Can I add a little something?
Please.
I completely agree with them. The one thing I would add is, although we're the highest cost medical state, as I mentioned, we're seeing that in the exchange, people are actually gravitating towards some of those narrower network products, and they do it knowing what they're looking at. And so just to give an example, on the small group side in our new platform, we went into that choice model I described not knowing whether small employers would want to take up. It is effectively a defined contribution model. Some of the math is a little different because as people's ages are different, you kind of like a different dollar amount. But basically the concept is an employer goes in and says, that's what I want to contribute, this is the plan I'm choosing, and then the employees can sort of take that amount and then go shop with it. And we're finding that 2/3 of the new groups that are coming into our platform are taking up that option, and people are peeling off and picking those lower cost products. So I don't know that it'll be a sea change necessarily, but when we first kind of launched this effort, a lot of very smart people told us small employers won't want to do that. They will want to be paternalistic, and they do want to control the exact plan that their employees select and land in. And we're finding that that seems to be breaking up a bit. And so again, our 250,000 people who shop, with the fact that we have the lowest cost average PMPM of any state in the entire country for an exchange, but are the highest cost state, when you look at what the plans people are selecting, when they can see side by side the price difference, they're doing something different. And the price difference can be 40% for the exact same generosity level. And that variation is about network. So I do think there is some hope for, if people have the right tools, maybe they can start to change some of that behavior.
If I could, Karim, too, and it is looking at how to change it and not lose the value of that. We can all understand the business end of it. If you want to stay in business, you're looking to, let's say, be ahead of your overhead by 3% or so at least. So if you're running a healthcare network and you're trying to get 103% of your overhead to reinvest it, no two are identical. So in the old days, it was true that you charge a little more perhaps for routine things so you could afford to do the more expensive ones that, that came out at the end, depending on how many babies you delivered, how many cancer cares, how many appendicitis in your network, which is different than somebody else's network. You had to come out, both had to come out at 103% or so to reinvest in the network. So the pricing on a per procedure is very difficult to say it had to be the same in one place as another, because if you were doing lots of certain procedures here and not so much over here, you had to charge a little more over here to be able to afford to do it in your community setting. And we all had community settings, and people didn't go outside those community settings, and so the pricing structures were different. And now we're trying to get them where they're similar, if not the same, similar. And it's true to say that a lot of the procedures you can do outside of the system, because some of those procedures were money makers for the system in order to do some things that were not money makers that the public needs the system to do. And we don't want to lose the ability to do those things, whether it's behavioral health, whether it's the opioid situation, where it's things that are expensive to do and not money making for the system. The system needs to still do them, and we have to find a way to support the system to do that. In the old days, it was the cost shifting by commercial or public cost shifting. We're not able to do that so much because we're going to a pricing schedule. We have to figure out how to do that without losing the system.
Very good, very good. The next question I would have is this. It seems like innovation and technology has made so many things in our lives cheaper, right? The smartphone is much cheaper than it was when it first came out. A flat screen TV, I probably have 10 of them because they're so doggone cheap on Black Friday. So the question is, there's only two things that haven't gotten cheaper with innovation: education, higher education, and healthcare. What can be done through innovation and technology to make those costs come down for the end user? Jennifer, I'll start with you.
Sure. So one of the things that we're doing that I think touches on this has been expanding our telemedicine benefit. So most of the plans offer some type of telemedicine benefit. And the biggest challenge with that has actually been adoption. So although we have this lower cost way of delivering care where you can basically pick up your smartphone and get a clinician on the line, we just still haven't seen the adoption. So we are actually partnering with Partners Healthcare to have them be the front line of our telemedicine benefit. And we're branding that Partners Healthcare on Demand. These partners clinicians have actually accepted a very low competitive rate for that service. And our hope is that by marrying the partners brand with this easier way to get care, that we can actually drive up the utilization. But we do certainly see virtual care as one of the ways that we can harness technology, harness that innovation, and deliver something that's lower cost to the market and more convenient for members.
Alan, anything on that?
Keeping people healthy would be the first best way. Certainly, what we call wellness programs, utilization of the system has gone up. You know, you're right, talking about efforts to consolidate and take advantage of size to reduce the cost hasn't helped us yet. The utilization has still been extremely high, and there's still what we saw in the 90s that we thought was going to really make a big difference, the consumer increase in deductibles and copays. We said, the fact that people are going to the most expensive places under first dollar coverage is because it's like an open bar at a wedding. Why wouldn't they? It's paid for, you know, and why wouldn't they want to do that? We said, as soon as there's a consumer response, because they have to pay, even if it was $1,000 to go have a baby delivered in Boston versus the community versus free in the community, maybe somebody would say, oop, I think I'm going to have the baby delivered in the community. It hasn't happened yet. So I don't know if there's going to be a consumer response in the long run. We think so. And it's going to be providing, if we provide enough opportunity for the consumer to make a choice, we do believe that the market will play a factor in the future for healthcare. Certainly from the healthcare industry point of view, that's what we're trying to do, that's what we're thinking. And we're trying to prepare for a consumer response. It's only going to choose the right place to go for healthcare and cost.
Very good. Audrey, this question's for you. So it's kind of touching on and piggybacking on Alan's comment about the market. So the president signed the executive order allowing to purchase healthcare over across state boundaries. What's the state stance on that? Can you kind of touch on that a little bit?
Sure. So just in the way of context, so last October, the president signed an executive order that encouraged a number of federal agencies to issue regulations that would create new pathways for employers and individuals to be able to buy across state lines and join something called association health plans and also something called short-term limited duration plans, which is more for individuals. So each of those have their own sort of technical detail around them, but they're all really designed to create off-ramps for kind of state-regulated markets. And so these are the kinds of plans that the connector, working with the Division of Insurance in the state, as we've looked at, would create kind of risk splitting in the market, which we have concerns about. So what that would do would be to create a parallel small group market where groups that perceive themselves to be kind of healthier, maybe they don't have as many female workers, so they don't necessarily need plans that cover maternity benefits. So what happens when certain small groups start kind of peeling off and buying plans like that is the rest of the market that's left behind faces higher costs. And so we've looked at this from an actuarial perspective, and that is borne out. So the connectors, as well as the state's Division of Insurance, we sent in letters to the Department of Labor that issued those regulations. We've been watching them really closely. The final rules haven't been issued, but just at a high level, the state has a degree of concern about creating these kind of shadow markets that are not as regulated and don't require the same amount of consumer protection and benefit standards, because anytime you allow people to choose who's regulating them and what the regulatory standards are, there's going to be kind of a disaggregation factor that leaves those with higher health needs or certain demographic factors, maybe older workers, more female workers, et cetera, people with chronic health conditions. It's destabilizing to the market. So we would expect to see premium increases in Massachusetts as a result of those proposals. So we're watching with concern. That being said, we know the reason that some of those policy proposals may be attractive to some is because they provide the promise of a cheaper insurance product. But I think the way we're thinking about it is we need to do more to make sure people can purchase more affordable coverage without doing things like disaggregating risk and peeling away benefits and consumer protections that have been a hallmark of the market in Massachusetts for the last 30 years.
Very good. 2 questions left, and then we'll open it up to the audience. So, Alan, I'll start with you on this one. So this is kind of a touchy one, so I'm warning you early, okay? So the cost of medications, right? We always hear about the cost of medications skyrocketing and pharma's role in that.
Right.
Talk about the role that medications and pharma play in the cost to employers and employees for healthcare across the state right now.
Well, there's no question. We budget every year when we put our budget together for the hospital care. We have the laboratory expenses and the pharmaceutical expenses, and we have a very hard time staying within that budget year in, year out. And it has been a bigger percentage of the cost of care. I know the argument is that good pharmaceuticals help you in the long run not need as much hospital care, but whether or not that's accurate in every case, it certainly is very expensive as you're doing it. And I think that tremendous advances in pharmaceuticals are definitely life-changing for so many people. So we don't want to thwart the progress in research for any reason, but must say that the cost in the healthcare, particularly for the aging population in the pharmaceuticals, is very, very high. And we don't have, from the healthcare network point of view, any control over that. So we're not quite sure how we're going to manage it.
Yeah. Jennifer, anything from your side on that?
I mean, I would just second that even from the health plan perspective as well, managing pharmacy costs is increasingly a bigger and bigger piece of what we do. If you looked probably 7 years ago, pharmacy spend was about 10% of the premium dollar. It's up to 20%, and about 90% of that is really being driven by specialty pharmacy. And so we are in constant discussions with our pharmacy benefits managers, CVS, Caremark, to make sure that we're getting the most competitive deals, holding their feet to the fire. We're trying to leverage plan designs where we offer a 2-tiered specialty pharmacy benefit so that members can try to make decisions around going to lower cost specialty medications when it's available, and really try to leverage what are called these rebates that we can get back from some of these brands if we can drive volume to certain medications. But it continues to be a challenge. It certainly takes up more and more of the premium dollar that then can't go towards other things. So, I think it's really, it's a federal issue as well at this point.
I can tell you what's happening from the physician's perspective. I don't know if there are any physicians in the room, but there's much more awareness now when the physicians are writing prescriptions for the cost of what it's going to be. A few years back, it was just, here's what you need, and there'd be a prescription, and you could ask the doctor, do you know what this costs? I don't have any idea, this is what you need. But now there's really a high awareness among the physicians about the cost, and so they're careful about the prescriptions, much more so than in the past.
Very good. So my last question before we go to the audience is this, and I'll start with you, Audrey. What one takeaway would you give a small business employer around what they can do to help reduce the cost of healthcare for their employees and for themselves?
That's a great question. So I would say shop. I would say looking at your options is really key. I think and this is very understandable, small business owners are busy, they're running a business, thinking about health insurance and the nuances of the market, it's a lot to take on. But, and coming back to your question about technology, because of things like investment in technology through exchanges, for example, it's easy for a small employer to come online and look at what's available in the Massachusetts market. We are so lucky in Massachusetts to have as many local carriers as we do, who are among the highest performing in the entire country. At the Health Connector, we talk a lot to officials in other states running their own exchanges. They would love to have the number of carriers we do in our market, on our shelf, who are competing on value and benefits. Elsewhere in the country, you know, the small group market may have one or two options, and there's monopolistic pricing and all other kinds of dynamics going on. So the fact that here we have so many high value choices, and I'm not sitting here saying that the lowest cost option is always the right thing. There may be very good reasons somebody wants a more robust network that is higher cost, and that's great. We want to give people the tools to see what's out there. What we find is most small employers don't even know about the lower cost options that may be a narrower network that do have people, you know, doing their deliveries or their knee replacement surgery at a community hospital rather than an academic medical center. They have the right to look at that and see that, and as I mentioned, that price difference can be really huge. It can be up to 40%, but they can't see that if they don't look and check and see what's available. So that would be my advice to a small employer, is your market is more competitive and has more variation than you probably think, and there are tools the state has invested in to make sure that you can go see what those choices are, and you as a small employer don't even have to make that choice for your employees. You can just set them loose in the market and they can make their own decisions, and you may be surprised by what they do.
Very nice.
And even if we could, I know we're running against time, great advice. But share it with the employees would be the second thing. I can remember when managed care came in the 80s, and one employer, it was a small employer, said to his employee group, private company, we're going to go managed care, which meant reducing choices about what doctors to go to, what facilities to go to, and there was rebellion from the employee group who had first dollar coverage, go wherever you want for all those other years. He said, well, here's the deal. I'm going to be able to save $4,000 an employee. You get $2,000, we'll keep $2,000 at the company level. Tremendous buy-in, right? Overnight, he had tremendous buy-in from the employee group because they realized that it was an economic, not giving up healthcare because they still had good choices, but more economical choices, and they, the employees, were going to benefit by making those choices too. And so that's a years ago thing, but it worked out very well, and I bet it would work out still if you share it with the employees, your own cost savings by having limited networks. It is a great way to go.
Very good. Jennifer?
You did steal mine, Alan. So I was going to say employee education, because in helping your employees be better consumers of healthcare, you know, and this is something that really you can tap into your carrier like Neighborhood Health Plan to help with. We have a dedicated account management team for small group business, and we will come meet with your employees, you know, more than once a year and help them understand the tools and the resources that are available. Things like taking advantage of the telemedicine benefit, taking advantage of some of the shopping programs where members can receive money back if they make better consumer decisions. These can't be just one-time communications, or they can't think that their health plan just ends at getting their ID card. You know, if we can really educate, I think, employees and their families to be better consumers of healthcare, that will go a long way towards controlling cost.
Very good. And like any good moderator, we're right on time. So if any questions for this esteemed panel, I will take them now.
We offer health insurance to our employees. Can they buy dental insurance through the connector only?
Yes.
Only dental.
Yes, they can. So both individuals and small employers can shop for dental insurance along with their medical coverage through us. Yes.
Very good.
Audrey, you touched on this, but I want to make sure that I'm understanding clearly. So on your site, if I need to have an ACL reconstruction, I can go on and I could see that they're typically $15,000 at South Shore Hospital. They might be $9,000 at some other hospital in Framingham. It's that clear?
So
Does it kind of go over toward some of the higher end drugs and the probabilities of success from those drugs?
That's a great question. So to be clear, what we do is provide side-by-side comparisons of insurance products. So what you can see is benefits covered, network, provider search. You could look up and see, oh, okay, my PCP and my specialist are in this, this product compared to this one. So that's what you can see. We don't get down into the detail of like this procedure costs this much at this different hospital. The state's Center for Health Information and Analysis just launched a website that provides procedure level price information. In a future world, we'd like to link to that so when people are shopping for insurance products, they could say, I'm interested in a narrower network than maybe I've done before. Let me go look at what that would look like based on the procedures I might be envisioning for this year. But what we focus on is the insurance product itself, benefits covered, and network and price.
Right. So you foresee a day in the future where that's emphasized a lot. I mean, I would
do.
never buy a car without knowing what it was going to cost me beforehand.
Right. Yes, I do, and I think decision support tools and transparency are sort of the future of our website. But at this point, I think for the typical shopper of insurance, they may not be exposed to that underlying sort of unit price, and maybe there's a whole other conversation. Maybe they ought to be.
This is post-insurance.
Yes, exactly. So,
I'm insured,
yep.
I need something
Yep.
done.
Right.
And that's available at the plan level.
Yeah.
So we have decision support tools that would let you go in a certain zip code, figure out who are going to be the providers, what it's going to cost me. And the other piece that a plan can layer in is how much of maybe your deductible you've already spent. So it's taking your benefit design, marrying that with the cost of that provider to give you the most accurate view of what your out-of-pocket would be.
Very nice.
We touched upon Big Pharma, and I guess from my standpoint, every time I'm watching television and one of these advertisements for some drug from some drug company comes on, all I look at and think about in my head is, what a waste of money. Why are they spending all this money on advertising when it's I'm not going to go to my doctor and say, oh, I saw an ad for this drug, can I have it? I want my doctor to be telling me the drugs that I need to take. So why are they wasting all this money advertising?
Well, the fact of the matter is a lot of patients do go to the doctor and say, I want such and such, and then the doctor has to talk them out of it. And as we all know, the pressure on the physicians now with the 15-minute visits or 7-minute visits or whatever they're supposed to be doing to be productive, they have to spend extra time convincing the patients they need less or they should go somewhere else. And in a sense, they look at their own watch and say, oh, what the heck, I want a happy patient. So rather than try to convince the patient, less is still okay and even better in some cases. Sometimes they do, sometimes they don't. But the fact is that the physicians do get a lot of requests that I saw this great thing on the TV, doc, that's what I want. And the doc has to talk them out of it. And sometimes they do, and sometimes they shrug their shoulders and say, yeah, go ahead.
Yep, one more. There we go.
Yeah,
Oh, wait 1 second. Should we bring the microphone?
I don't know if I need it.
Thank you.
Yeah, so I'll add on to that a little bit. So I really think that it's a patient-focused, organization where the patient goes to the doctor and he says, no, I want this drug. I really think that the access to free information is really the key reason for that. How do you think that affects the healthcare system in general? The fact that we have more information, the fact that we want to link more sites to it, more pricing plans, how will that affect it in the future, and where do you see that going?
I'll just speak from the insurance purchasing perspective, which is, I think, more information is good to a point. I think it has to be curated. I think the typical person or small employer can struggle with input overload. Insurance is extremely complex, even for people who are professionals in health policy and health insurance. And so I think the trick is figuring out what are the operative pieces of information a person needs to make a smart choice. And I think that that's always a work in progress in terms of figuring out what it is people understand. The Health Connector surveys its membership once a year to try to understand how many of our members understand what a deductible is, what a copay is, what a premium is. One of our goals is to make smart shoppers, and so we have an emphasis on health insurance literacy, but it is a struggle. A lot of people don't understand these terms, and as insurance gets more complicated as a way to try to bend the cost curve as there's more of a cost-sharing burden on individuals and things like co-insurance come into play. It can get really challenging. And the connector, for example, we cover a really wide range of individuals and small employers. We've got, lower income individuals who may, not have had experience with a commercial insurance product before, so they're seeing features and terms they haven't seen. So we have to do work to make sure they do understand and don't have surprises. But I think there's a whole other universe beyond just insurance purchasing where that comes into play, like prescription drugs and how much information is processable or able to be acted on in a helpful way.
Very good. Any other questions? One more in the back. Yep.
Quick question here. Some family members that I have are getting their prescription drugs actually from Canada, and I didn't know if that was something that's being addressed at all by the insurers. I don't even know if it's legal, so I probably shouldn't have said that.
Anyone
Do you
guys
want
want to
to
touch
take
on
that
that?
from? I mean, we, at this point, it's not something that's supported by the mass plans. Certainly we understand some individuals are doing that. You hear that through the market, but that's not.
Something that insurance plans eventually provide?
I don't think, right, I think that's a legal and federal, probably legal issue.
So I'm just going to take my name badge off.
That's right. Yep. Have security come.
I'll try to ask a question that you can answer, legally answer. Can you talk to me a little bit about what your organizations are doing with regard to care coordination? Because I think you, Alan, you kind of referred to the everything has gone to fee-for-service model, and we've ground everything we can out of that. Used to be you'd go to your doctor, and he was kind of the care coordinator, your primary care physician, knew what you needed, and he'd advise what was best for the whole patient. Now it seems like it's you get this service here, that service there, it's not coordinated, and as a result you have people working at cross purposes, you have prescription drugs that conflict with each other, and that seems to be where a lot of the costs are going too, is that everybody wants to sell as much as they can of their thing, but not necessarily what's best. So how does the insurance business addressing that need today?
I mean, care coordination is certainly a focus of ours, and I think it's one of the things that we can bring value, because as we look to our primary care physicians to really coordinate care at the health plan, we have the benefit of the data where that member may be seeking care outside of that provider system. And so our goal is to get the best data that we can in the hands of that provider so that they can appropriately manage care. So for example, our data to providers refreshes within 48 hours of receiving that member's claim, maybe from another system. So it lets them know, hey, this member just went to the emergency room, out in Framingham, even though that hospital might not be part of my system. And so it gives then that provider the opportunity. And then we, in our arrangements with providers, have created incentives and financial support for them to hire nurse case managers, for them to hire even college-educated navigators, because a lot of this is even just coordinating appointments for members, and it doesn't need to be necessarily done by a clinician. And so the more that we can do to support providers to manage that care, we understand that they really want to hear from their primary care physician on this more than they do from their health plan. So our role is to really empower them through information delivery.
So I'll wrap it up there. So a couple things when I wrap up. I want to thank each one of the panelists, because what we tried to do at the association was bring three different perspectives, right? We have someone from the carrier side, someone from the provider side, and someone from policy. And I think when you get all three different perspectives, it kind of paints the picture a little bit better and clearer. So I would definitely want to thank the panelists. Each one of these panelists are heavily invested in the New England Business Association for one reason or another. Alan, I actually roped him off last week at a different meeting, and I said, hey, I need someone that does what you do. Can you come here? And he said, I'm retired. I said, perfect. I mean,
No excuse.
But the partnership we have with the Connector is unique, and it's something that we are very, very proud of, because as I hear through all the businesses throughout the Commonwealth and actually throughout the region, healthcare is one of the #1 issues that they have right now. They need to provide it, they want to provide it, they just want to understand it and offer quality care to their employees. So I thank each one of our panelists. Jennifer, thank you for coming. Alan, thank you for coming. Audrey, as always, thank you. And I thank all of you guys for showing up as well and supporting the New England Business Association. Have a great rest of the day.
Nice job, Audrey.
Mike.